Yeah. So basically, the inoperable locally advanced lung cancers. Um, this is the most important statement that I would want to make, that the concurrent chemoradiotherapy, there is a reduction in the risk of death at the end of 2 years as compared to a sequential chemoradiotherapy, which is a 7% reduction as compared to the radiotherapy alone. So in clinical practice, unless there is a problem with the patient, the concurrent chemoradiotherapy should be the standard of care in such patients. Next slide, please. So based on that, there was a small study which was done by the same group who had published this paper that we are going to be discussing. So they did they looked into the association of a planning target volume with patients' outcome in inoperable stage 3 lung cancer, which was treated with chemotherapy. Next slide, please. So the study revealed that the PTV basically the primary tumor and the lymph node which is involved, not the elective nodal irradiation, is an important prognosticator factor in the patients with inoperable stage 3 lung cancers which receive conventional radiotherapy. Basically, multiple parameters were looked in, but the most important parameter which came out was the PTV. So patients who had PTV more than 700 cc represented a special subgroup with a significant lower locoregional control, and with a worse PFS and overall survival rate. So this study basically recommended evaluating PTV as an additional stratification factor in clinical trials of a multimodal therapy in inoperable lung cancer. So this multimodal therapy part, where we were just using chemotherapy and radiotherapy, this is where the new immune checkpoint inhibitors had come and were also enrolled into offering treatment to the patients. Next slide, please. So is the graph visible?
Yes, sir.
So if you look at the graph onto your left and onto the right, onto the right is the overall survival, the progression-free survival, and the locoregional failure survival. So they are much better in the arms which received concurrent chemo-RT as opposed to patients who received just radiotherapy and followed by a sequential chemotherapy. Onto your right, it is the T stage and the N stage match graph, similar to what we are seeing on the left. Next slide, please. So this is the study that we need to be discussing here, is the impact of the PTV on the progression-free survival in inoperable stage 3 lung cancer, which were treated with chemo, immuno, and radiotherapy. Next slide, please. Next. So this study, can you go back, please? The previous slide. Yeah. So basically, this study had evaluated use of checkpoint inhibitors also along with the standard chemo-RT. Next slide, please. So prospective data of 33 consecutive patients with inoperable stage 3 lung cancer, which completed chemo-RT with sequential durvalumab or concurrent and sequential nivolumab were analyzed. So different cutoffs for PTV were evaluated, again similar to the previous study, and look for the association with the PFS survival. Next slide, please. All patients received at least 60 gray of radiotherapy. That means basically 30 fractions of radiation, which went on for 6 weeks. There were patients who have actually received 64 gray also. Most of them have received 2 cycles of concurrent platinum-based chemotherapy, that is from day 1 and day 21. Median follow-up for the entire cohort was 20 months, and the median overall survival was not reached. The median PFS was 22 months. Next slide, please. In this study, patients with PTV more than 900 cc had a significant shorter PFS as opposed to what we saw in the concurrent chemo-RT arm, which was 700 cc. So it is in a range of 6.9 months versus 22.8. And the extracranial metastasis-free survival also was poorer in these patients. Furthermore, patients with PTV more than 900 cc in specifically stage 3C disease had even worse PFS as compared to the other in subgroup. Next slide, please. So the conclusion, PTV has a significant impact on the PFS and the EMFS after the CRT combined with concurrent or sequential checkpoint immune inhibitors. Patient with PTV more than 900 cc had a significantly shorter PFS and EMFS. Next slide, please. Next. So legal entity responsible for the study were the authors. Funding was not received. Basically, it was a research grant funded to the institution itself, and all the authors have declared no conflict of interest. Next slide, please. So uh, this this graph that we're seeing again on the right and my left and onto our right is basically the overall survival, the progression-free survival and local region-free survival in these studies which have used durvalumab as a adjunct following chemo-RT. So it is clearly visible that the arm which received immunotherapy following chemo-RT did better as opposed to the ones who just had chemo-RT. Next slide, please. Thank you.